Think it's good in the pocket or something. All right.
Good morning, everyone. Introduce Dr. Kramer,
Thanks, Keith. Don't even. All right. Good to see you guys. So I know I don't think I turned this in a timely manner, so probably no one has any idea what I was planning on doing. And here's what it is. I think this is Whitney's fault. I think I asked her a couple weeks ago, what do you want me to talk about? And she said, was there anything new? I said, well, not really. But I got thinking, well, there is. So we'll go with this. How's this thing work? No? 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 Should I use the right one?
Yeah.
No? There. All right, so most importantly, I was told I had to put this in, so I have nothing financial to disclose and nothing else. The only thing I'm going to disclose to you is that in lieu of any sleep last night, I'm doing this on coffee and joy of living, so bear with me if I ramble or anything like that. So, this thing, I'm figuring out what, there we go. So, little background first. I think what a lot of us or most of us probably know something about here, background of what we're talking about when we're talking about ovarian cancer. We're in general, when anyone talks about ovarian cancer, comes in, asks you a question, anything like that, we're talking about epithelial ovarian cancer. We're not talking about the 10% that's stromal or germ cell. We're talking about, you know, the standard 4 histologies, serous, endometrioid, mucinous, and clear cell. So, not going to talk too much about the other things today. Incidence of ovarian cancer, second most common gynecologic cancer. Most women in general population risk about 1 out of 75 chance of getting cancer in her lifetime. In 2015, the final numbers are obviously not out there, but they were expecting about 22,000 new cases, about 14,000 deaths. So a high fatality to case ratio, as you can see. 11th most common cancer in women, but the 5th most common cause of cancer death. We all know some of the risk factors, some of the factors that are associated with prevention, and you can see them up there. I'm not going to go through them too much. Basically, you know, like anything, you know, some of this stuff comes and goes. Some of us, you know, have been known risk factors since, you know, Dr. Jernigan was in residency. You know, some of the stuff comes and goes. Morning. You know, the whole talc exposure was a giant thing when, you know, I was in residency, went away, and now is back. So, again, boils down to we don't know what causes it. It's a difficult cancer to detect, so the symptoms are vague. And again, belly pain and everything else tends to be gastrointestinal. So, you know, I see women all the time, you know, they've been complaining about these symptoms for months. And, you know, they've been tried on antacids, you know, all kinds of stuff. They're looking at their gallbladder. And then finally we find evidence of ovarian cancer. And so, you know, unfortunately, probably 3/4 of women are going to show up with stage 3 or 4 disease when it's detected. And this just breaks it down. I didn't tab right, different version of PowerPoint. But again, you can see that stage 1 and 2, you're looking at about 20-25% of cases, and the rest of them are going to be advanced stage. So in keeping with looking at kind of what's changed now with ovarian cancer or recently, standard treatment, you know, again, we know a lot of this, but some of this stuff is advancements that we saw, you know, when I was in residency and in fellowship, and it's kind of been interesting to see how that has changed some of the numbers. But as you know, generally speaking, ovarian cancer is going to start with surgery. Our attempts have always been to cytoreduce it, debulk the cancer, get rid of it if you can. And that's changed. You know, when I started out, our goal was to get things less than 2 centimeters. Then it migrated to 1 centimeter, then 5 millimeters. And now, for the most part, we're shooting for complete. We want to not be able to see anything when we get out of there. We've seen improvements because we think of debulking. And it'll be interesting to see if we see continued improvements as we've continued to become more aggressive. This has changed. You know, one of the things that kind of sticks out to me is when I was in my fellowship, faculty that I had were quoting a paper that came out of Duke that said if you've got to do colon surgery or bowel surgery on a woman with ovarian cancer, she was gonna die and there was no reason to do it. And you know, you think about where we've migrated now, where it's not uncommon to do that, and you know, in an effort to try to get rid of everything. Chemotherapy. Pretty rare that a woman with ovarian cancer is going to escape treatment without chemotherapy. Even early stage 1 cancers, depending on cell type grade, will get chemotherapy. The treatment's fairly standard. Again, that's something that's changed in 20 years. You know, when I was getting through my fellowship, that was when we were changing over to the standard regimens of platinum drugs and taxane drugs, or what the standard of carboplatin and Taxol is nowadays. So, you know, even that chemotherapy that is standard now is something that's relatively new. Consolidation of treatment has been something that's changed significantly. You know, we tend to think of, you know, oh, there's a GYN oncologist. Well, you know, it's about 40 years old. So, you know, GYN oncologists have not been around for a particularly long time as a subspecialty. So, you know, there's pretty good evidence, papers that are out now that suggest that a woman who is cared for by a GYN oncologist, as opposed to, you know, some piecemeal fashion, probably lives a year or more longer. So, you know, consolidation of treatment seems to be of some benefit. And then risk reduction. And, you know, about 15 years ago, we realized that you can identify women who have a BRCA mutation. If you can catch those women when you find that mutation, you can catch them before the cancer develops, take their ovaries out, you're preventing some cases. And we've actually seen decreased number of cases over the past probably 10 years of about 2%. And that's not, sounds like a small number, but it's a statistically significant number. And you know, if you see that change going up, you're going to be pretty concerned. So we've actually seen the numbers going down. So what have we seen from this? And you can see the 5-year survival rates by decade. And so, you know, if you go back to, you know, really the numbers that I was seeing when I was in training, you know, not even 40% of women were making it 5 years. And this is all women with ovarian cancer. And, you know, ending 2011, which is the last numbers that are published, we're getting close to 46, you know, up around 50%, which is pretty remarkable for ovarian cancer. But despite those improvements, despite those things that have changed in the past and we're seeing benefit from, the mortality from ovarian cancer has pretty much stayed the same. So what we're seeing is, you know, women are living longer, they're just living with their disease. It's pretty remarkable to get, you know, a woman with ovarian cancer. Again, I always put this in the perspective of what I saw when I was coming out. And, you know, the trial that changed the treatment, the chemotherapy of ovarian cancer in 1996, the survival in that study was 2 years. And, you know, now we're getting women out to 5 years, yes, with disease, but in 20 years' time, that's the kind of change we've seen. So as we look to things that, you know, we can maybe change and things that are changing now, this is a little diagram that I took off the NCCN guidelines. Excuse me. which sort of boils down care of ovarian cancer, treatment of ovarian cancer, and where we can impact it, what we do. And not so important to look at that, except that there's various places along there where we can make changes and can have impact. So I'll just come back to this slide periodically just to plug in something red down there to say, okay, here's some things that are changing recently, some things that you guys are probably doing or need to be aware of, some that's probably more me involved, but things that I think over the next 10 or 20 years, we are hopefully going to see some of the changes that we've seen over the last 10 to 20 years. So I already talked about genetic stuff. 15 years ago, we identified the BRCA mutations, found out that you can screen for women. We would see women in the office, they'd have a diagnosis of ovarian cancer or a family member. We'd say, okay, what's your family history look like? Let's try to figure out if this lady's got a risk for cancer that we can modify. So hereditary ovarian cancer, only about 15% of ovarian cancers are hereditary. But again, we really think that that's part of the reason that some of the numbers are going down, because we've identified some of those women and prevented it. There's other mutations. Certainly there's going to be other mutations that probably down the road we're going to find, but BRCA1 and 2 are the most common. They're, as you know, again, thought of as tumor suppressor genes. So if there's double-stranded DNA breaks in a cell, BRCAs come along, they repair that. Women who have a deficiency in one of these have a risk of ovarian cancer in their lifetime as high as 50%, in some studies maybe a little bit higher. So again, past 15 years, you've been working at taking those ovaries out, preventing cancers. And as I said, what we used to do is we'd look and we'd say, okay, does this woman look like she has some risk? We would talk about, hey, there's a number of family members who've had it, you've got it, you've got a first degree, da-da-da. And what we found in doing some of the BRCA stuff is that probably about a third of women who have a hereditary cancer don't have a close relative with an ovarian cancer. And what we've also found, always tend to think of the BRCA mutations as leading to an earlier age of ovarian cancer. About a third of the women show up with that cancer after age 60. So in general, and again, this is probably more for me than you all, but SGO the Society of G1 Oncologists, came out with a statement that basically recommends genetic counseling and genetic testing for every woman who's diagnosed with an ovarian cancer. So that's obviously going to mean a whole lot more screening. It's actually prompted our genetic counselor, I think, to leave because she's been totally overwhelmed by gynecology stuff in the last year. Essentially, every woman who I diagnose a peritoneal, ovarian, or fallopian tube cancer is going to see the genetic counselor and going to get genetic testing. So we're not going to miss 1 out of 3 women who have a hereditary cancer. And again, it's not going to impact that woman. She's been diagnosed. She's in the process of being treated. But it's going to impact her family who, again, you guys are probably going to see an impact. More important for you, just a couple months later, SDO put out a position statement on inherited cancer. And again, it's really busy. It's really small. Just wanted to see how much stuff I could fit on the slide. The upper part is women who are affected with cancers, and hopefully that's caught, sometime when they're not coming in for, their annual examination. But at the bottom, women unaffected with cancer who should be considered for screening, or if they have a first-degree relative or close relatives who meet the criteria above, or if they have a close relative with a mutation. And some of these definitions have changed. We always used to get worked up about first-degree relatives. Well, then they expanded to first and close. They've expanded a bunch of different things and changed definitions. But essentially, First degree relatives going to be sister, daughter, mother. Close relatives goes out 3 degrees. So if they've got a close relative, that can be a cousin, a niece, a nephew, a great-grandmother, a great-granddaughter. So it really opens up what you're looking at when you're saying, okay, this lady has, you know, a cousin with ovarian cancer and a great-grandmother with ovarian cancer. It's probably someone you should consider for genetic counseling and screening. So again, as you know, and this is not anything different, you know, we've been doing this for 10 years, 15 years. You identify someone with a mutation, you consider them for risk-reducing salpingo-oophorectomy, generally recommended by age of 35 or 40 once that woman is done childbearing. It reduces the risk of ovarian cancer anywhere from 80 to about 96, 97%, depending what study you look at, reduces their risk of breast cancer by 50 to 80%. We know, I still generally recommend, you know, if you're doing it, do cytology, do pelvic washings. There's been a couple things that have come out real recently within the past, year, suggesting that maybe the cytology is not necessary. It's easy to do it. It's not going to hurt anything. We're not talking about worrying about some sort of false positive that's going to doom someone to, having more surgery or chemotherapy. We're talking, about spending a little bit of money that maybe isn't terribly helpful. Take the tubes and the ovaries out. There's always been a concern, you're leaving a little piece of tube in the uterus. I think it's important to know that that little piece of tube has never been found to generate a tubal or an ovarian cancer and has never been implicated in a primary peritoneal cancer that develops after taking the tubes and ovaries out. So that was always something people got worried about. Should we be digging the cornea of the uterus out to get the whole tube? Not necessary. Be prepared that you might find cancer at the time of surgery. Anywhere from about 2 to 9% reported that you're going to find cancer. And fortunately, most times those are occult cancers. But, if you're thinking about doing the surgery, make certain that you counsel that woman, not only the stuff you're going to, okay, this is surgery, this is how we're going to do it, we might have to open, you're going to go through menopause, but there's possibility you're going to find a cancer. There's possibility she might be looking at more surgery right at the time, if you've got someone around that can do it, or a second surgery down the road. You also want to make certain they know they can still get peritoneal cancer with the ovaries and tubes gone. But again, like we talked about, this has probably had a part in decreasing the incidence of ovarian cancer. There's really been nothing else that's changed with screening or detecting cancer early that's been effective. So likely what we're seeing is the benefit of taking out some of these ovaries and tubes in women who have a high risk. There's now the option of salpingectomy, just taking the tube out in these women who have BRCA mutations. Again, probably something, it's investigational, but women, especially with a BRCA2 mutation, they're prone to their ovarian cancer a little bit later. So, they have the same risks of taking their ovaries out, putting them through menopause, putting them the risks of that. If there's a possibility of reducing their risk by taking just their tubes, it's certainly something that you can consider and then perhaps put off taking the ovaries a little while longer till they get a bit older. But that brings up the next, we're preventing some ovarian cancers, and now that brings up the whole salpingectomy thing, which again, you guys have seen, and I think probably a fair number of you, if not all of you, are, doing salpingectomies at the time of hysterectomy or surgery. But this comes from some of the data that we've gotten from the BRCA surgeries. So we've always talked about the origin of ovarian cancer coming from the surface epithelium of the ovary. But, people who are a lot smarter than me have looked at that and they've said, well, how is that? You know, we have those histologies of ovarian cancer. They all kind of recapitulate other organs. Okay, so serous ovarian cancer is, well, it looks like fallopian tube. Endometrioid, it looks like endometrioid. Endometrium, clear cells, kidney. You know, it looks like it comes from some other tissue. Everyone just said, well, yeah, that's the ovary. It can make a human. It can make a serous cell, you know. So, but the other thing that always kind of stuck, again, to people is there doesn't seem to be a pre-malignant phase of this. You know, it's part of the reason people said, well, screening doesn't work, because if there is a, you know, a dysplastic process, if you will, it's short and we can't find it. Well, pathologists who started looking at these tubes and ovaries that were coming out in these risk-reducing salpingo-oophorectomies were finding something that they refer to as serous tubal intraepithelial carcinoma. And in about 50% of the occult cancers that they were finding this intraepithelial carcinoma, which in essence is a severe fallopian tube dysplasia. So we're finding this stuff that looks like it's pre-malignant in the tubes. And so people started suggesting, hey, is this where ovarian cancer is coming from? You know, you think about taking out some of these ovarian cancers that you guys have all seen, and you know, you can't even tell what the pelvic organs are, let alone, you know, did this start in the ovary or the tube? And you know, if you talk to the pathologists, they had pretty strict criteria of how they called this a fallopian tube cancer or an ovarian cancer. And you know, one of the criteria is that the tube had to be primarily in. How often are you seeing that in a big stage 3 or 4 ovarian cancer? You're not. So we think that the development of this may be coming from the tube. And again, this is something that you guys have all heard about. And that's where the option of the salpingectomy comes in these BRCA carriers comes from, is, hey, maybe we can take the tube out, decrease their risk of cancer, and leave their ovaries and all the benefits of keeping the ovaries. Too early to know. It's something that, you know, any of the women that I've been seeing over the past probably 6 months, I talk to them about as an option. Again, probably more important for you guys is the option of salpingectomy for all women. And again, probably, well, November 2013, SGO came out with a statement that suggested just that if you're doing surgery for some benign indication, hysterectomy in lieu of doing a tubal, if you're in there like, you know, Dr. Huffaker to keep something from dropping out, consider taking those tubes out. There's minimal additional surgery, there's minimal additional risk, and there may be some fairly significant benefit to having the tubes removed. So back to the diagram. Again, if we're trying to prevent stuff, but you know, we've made all of a 2% difference over the past, you know, how many years. So we're still going to see women diagnosed with cancer. We need to figure out, how do we treat them better? How do we get them to live longer? See if we can increase the cure rate. And you know, again, chemotherapy's changed, but there's ways perhaps of optimizing that. And there's been several changes that have been pretty interesting over the past few years. Again, standard treatment is straight intravenous chemotherapy, 2 drugs, carboplatin, paclitaxel, given every 3 weeks, 6 cycles, done. It's important to maintain the schedule. That stuff's been looked at. All kinds of stuff has been looked at with carboplatin, Taxol. We've added drugs to it. We've changed the order it's given, combined it with other drugs given in sequence. And carboplatin, paclitaxel has always come out being just as good, if not better, and safer. It's a well-tolerated chemotherapy regimen. The two most distressing things are hair loss and neuropathy. Hair loss to the woman, the neuropathy usually to me, because it's the thing that persists for years. But over the past probably 10 years, there have been some changes in how we give the chemotherapy and when we give the chemotherapy that I think over the next 10 years, we're probably going to see some, hopefully, benefits and changes from. The earliest of the three is intraperitoneal chemotherapy. Okay, so instead of taking the chemotherapy and putting it in the vein, we put a catheter in the belly and we put the chemotherapy directly into the peritoneal cavity. The idea behind it is, again, several-fold, but essentially you're bathing the cancer cells in chemotherapy. So you are taking a chemotherapy and directly applying it to the cancer cells. And the chemotherapy will invade into that cancer about 2 millimeters, and they talk about the onion peeling effect. So it'll kill that layer, it'll peel it. Next time you go after it, smaller, peel, peel. So you're not just getting the chemotherapy as a depot system too, because the body will gradually absorb that chemotherapy into the system, but you're getting direct effects. You're getting higher concentrations. It sticks around longer. So there's a lot of theoretical benefits to it. The most recent trial was published almost 10 years ago now. And it was the third of 3 big randomized controlled trials in this country. But GOG, Gynecologic Oncology Group, study number 172, was the most recent one to demonstrate benefit. And at the time it was published, it demonstrated an overall survival of near 66 months as compared to 50 months for the straight IV group. An improvement, do the math, of 16 months. But interestingly, the first study ever in ovarian cancer that demonstrated a 5-year survival, over a 5-year survival in women with ovarian cancer. So we're at 5.5 years. The 10-year follow-up, which has recently been published, still shows about a 10.5-month improvement in survival in women who got intraperitoneal chemotherapy. It's been broken down into subgroups. Women with BRCA mutations, women who are completely debulked seem to do better. And you think, okay, that makes sense. If you're starting with a tennis ball in there, you can peel off, 6 layers of 2 millimeters and you still have a golf ball. But if you're starting out with something that's microscopic, you're going to peel off probably everything in 6 cycles. Intraperitoneal chemotherapy has not taken off. There was a New York Times article just recently saying how women are being gypped out of this treatment and they don't know about it. It's another interesting one that's changed as I've been in practice and in training. The 3 big studies on intraperitoneal chemotherapy pretty much come out every decade. So they run some big study, and then when it comes out, it shows that intraperitoneal chemotherapy is better. All 3 of them have. Improved progression-free survival in all of them. When they come out, the issue's always been, by the time the study comes to maturity and is published, the standard arm that was compared to the intraperitoneal is not what we use now. So it's not a valid study anymore. The biggest thing is the toxicity. The side effects of intraperitoneal chemotherapy, it requires another surgery. You got to put a port in, you got to take a port out. Sometimes we'll leave the port at the time of the surgery. It's still going to have to come out. All of the side effects of chemotherapy are more profound, they're worse than with straight IV administration. You also have belly pain. Sticking a chemotherapy into your vein doesn't hurt your belly. Putting 2 liters of fluid into your belly and leaving it there and sending you on your way home hurts. There's catheter complications. It can migrate into stuff. It can get clotted. So it's not taken off because people just aren't comfortable giving it. They don't want to deal with the toxicity. They don't know how to deal with the toxicity. So it is something that just has not taken off in this country. Perhaps one of the biggest things is that people say, well, this is just a way to give more chemotherapy. You know, we're exposing these women to chemotherapy 3 times in 3 weeks instead of just once. We're repeating the one chemotherapy every 2 weeks. You know, so we're just giving higher doses for longer periods of time. And this brings to the next thing. About 3 years later, the Japanese Gynecologic Oncology group published a paper where they looked at dose-dense chemotherapy. So based on some of the data from breast cancer, they said, well, let's try to give more frequent and higher doses of chemotherapy. And so they administered the Taxol weekly with the carboplatin still every 3 weeks. And you can see up there basically what they came up with. They came up with, again, over 5 years, but 59% of women lived 5 years versus 51% in the standard chemo group. Again, most recent update on that showed an overall survival of 100 months in the dose dense. The biggest benefit of the dose dense seems to be in the women who are suboptimally debulked or have stage 4 cancer. So they have a lot of tumor when they start. But regardless, you're looking at 100 months there, which is, I can't do that math, but a lot of years. You know, when we're talking about getting women to, thanks man, see, the smart guy. When you're looking at, you know, just, you know, doing rah-rah because you got the 5 years and you got 8 years now, that's pretty significant. And again, something that's not been largely adopted in this country. And there's several reasons for that. There's been multiple negative studies in the past. You know, when I was a boy, we were doing 96-hour Taxol. We were leaving women in the hospital plugged up to Taxol for 4 days. And it proved nothing. We were doing bone marrow transplants and giving whomping doses of chemotherapy, and it didn't work. So there's been one study that suggests this benefit and a whole bunch of studies that suggest there's not a benefit. One of the other questions is generalization. And, you know, it sounds a little silly in one perspective, you know, but these are all Japanese women. And there has been a question of their ability to better tolerate high doses of chemotherapy. Not so much as they're, you know, tougher than you are, Jess, but that their bone marrow will support higher doses of chemotherapy, that some way, shape, or form they are able to better tolerate the bone marrow suppression. They don't get it to such an extent. So there's been confirmatory trials, GOD 262, ICON 8 are American and European trials looking at dose-dense chemo. It's a question whether they're going to answer or not. Some of the preliminary stuff on 262 suggests that there may be a 4-month improvement in progression-free survival, but it's also muddied because they added a third drug, and so there's a question that the third drug is the reason that there's the improvement. We're waiting for the final stuff. Despite all that, you know, again, if you look at the intraperitoneal and you say, okay, it works better if there's little stuff, the dose dense might work better if there's big stuff. Still, research continues to show that the most important things with ovarian cancer are the stage and how good a job we can do or do when we debulk the cancer. So the published rates of optimal and complete debulking vary. That's been since, you know, the day I was in training, and it's changed significantly as we've become more aggressive. Again, told you, you know, when I was in training, they'd have looked at the bowel and they'd have said, meh, she's just going to die, or we're going to make it worse if we mess with this, let's not. To the point where, you know, we're aggressively going after stuff. So the numbers have changed, but we're going to operate on women, you know, where it just doesn't seem to be the wise thing to do. And in keeping with that, people have suggested, well, if we know we're going to treat them with surgery and chemo, why don't we change the order? So let's give some chemotherapy before we do surgery. And in 2010, the EORTC published a trial looking at what's called neoadjuvant chemotherapy. So they used standard chemotherapy. They gave 3 cycles of chemotherapy up front, then did surgery, then finished with an additional 3 cycles of chemotherapy. And what they showed in that study was that neoadjuvant or NAC was not inferior to starting with surgery. So in other words, the median overall survival was pretty much identical in the 2 arms. It improved our ability to do debulking. So the percentage of patients where you could do optimal and complete debulking increased. So you'd see numbers of complete debulking of 20% jumping to 60%, of optimal debulking jumping from 40 to 80%. So there were changes in the ability to debulk these patients. We were able to do it with less aggressive surgery, less morbidity, less mortality, less blood loss, less all of those things that you don't want to experience when you do surgery on somebody, and the patient certainly doesn't want to experience. So it looked like a reasonable option. It was backed up with another trial. Don't ask me what CORE stands for. Everybody's got to do their fancy names for these trials. But just last year, again, demonstrated similar results. You start with the chemo. It wasn't inferior. We were able to debulk more patients, did it safer, easier. Similar outcomes to starting with surgery. Again, low median survival. So if you think back to the last slide, the overall median survival was 30 months. Well, we just got done talking about survivals of 5 years and 8 years, and now you're looking at 2.5 years. This study was 24 months. So it's whether or not where you use neoadjuvant is still not known. There have been 2 large meta-analyses done of it. Rob Bristow, who's a big, humongous proponent of starting with surgery. If you talk about neoadjuvant chemotherapy to Rob, he'll walk out on you or beat the crap out of you. And Kang, who showed no difference. So you got the same people looking at the same studies with the same meta-analysis and coming up with different results. But there's clearly benefits to it. Talked about them. One of the bottom one there is one that is a little less perhaps obvious, but makes some sense. If you've got a woman with big bulky disease, you start with chemotherapy, bless you. If the chemotherapy doesn't work, it's probably not a reason to do surgery. You can change up chemotherapy, but at that point, surgery is not going to help her. So you've used the trial to know if chemotherapy is going to work. And although Taxol carboplatin is safe and effective, it still only works in about 80–85% of women. So you're going to catch that 10–20% who don't respond. The risks and some of the things that folks like Bristow will say are you don't have an accurate diagnosis. Maybe you're tapping some fluid off, looking at some cytology. Maybe you're sticking a needle in, but until you get the ovary out of there, the tumor out of there, you don't really know. Are you increasing the possibility of chemotherapy resistance? You're leaving bulky tumor in there, so you got more cancer cells, more cell divisions, more chance of mutations, more possibility of resistance down the road. It's one of the theories of debulking, is you're getting rid of some of that tumor, so there are hopefully less clones that are resistant to chemotherapy in the future. And then people have talked about a concern about a more conservative approach, that if people start thinking, well, this is equivalent, and to this point we don't know for sure, that we're going to see more of this, let's get a biopsy of that and we'll start with some chemo and then we'll see about doing some surgery. And so if the studies eventually suggest that it's not equivalent, we've missed an opportunity here, and we've had a generation of women who've perhaps been exposed to something that's not as good as doing surgery up front. But again, through everything, it does seem to be of some benefit. And the trick now, I think, as we go down the road, is going to be figure out where it's of benefit. We know that women with bulky disease, women with stage 4 disease, you're going to look at some of these women, you're going to say, well, you know, she's got a lung met, she's got a brain met. I can't get that out with surgery, you know. It's probably somebody that you're going to start with other treatment before you start with surgery. You have to be careful about how you determine that. You know, all of these things have been used to decide. And functional status and health, you know, I mean, if she's falling all over the place all the time, can't walk, can't get out of bed, you're not probably going to put that lady through a big giant surgery. We've looked at nutritional parameters, platelet counts, white blood cell counts, the CA-125, and all of them end up being predictive about 75% of the time. CT scan, same thing. So, you know, there's not a perfect determinant for whether or not you decide to do surgery or chemotherapy first. I believe one of the things that's most accurate is a laparoscopy score. It'll be interesting to see if that takes off. I'm not sure how quickly I want to adopt it. But the most common one was proposed by a woman in Rome who they did laparoscopy and they scored 6 things when they did laparoscopy. So they looked at mesenteric changes, they looked at omental disease, they looked at diaphragm liver. They scored it. So there was a scoring system of 0 to 2, possibility of 12. Any woman who had a score of 8 or higher was not going to be debulked. So that's been modified a number of times. Anderson's modified it. People keep looking at it to see, you know. And so some folks are recommending now, stick a scope in, take a look. If you can debulk it, go ahead. If you can't, pull the scope out. You've not put her through a bunch of surgery, and you really have a good idea if you can start with surgery or not. Again, it'll be interesting to see if that takes off, if that changes. That's a hard thing to put into an OR schedule. You know, you say, okay, I'm either going to be doing a 15-minute laparoscopy or a flipping 4-hour debulking, you know. I mean, if you do that 3 times in a day, you could be home drinking coffee at 9 o'clock, or, you know, you may not be home at 9 o'clock p.m. So that's a little bit difficult, and I think it needs a lot more verification before it becomes sort of standard of care. But at this point, it seems to be about the most accurate thing for predicting. So despite everything, what time is it there, man? Oh my God. All right, I need to speed up. Not enough coffee. So despite everything, unfortunately, as you know, showed up front, the bulk of women are going to recur and they're going to die of their cancer. Recurrent ovarian cancer is essentially, a chronic disease process. You know, I've heard some of the big to-dos compare it to diabetes. You know, you're just always managing it. So the goals of treatment are different. You know, we're not talking about, trying to cure this anymore. Ovarian cancer comes back, we're not curing it. Okay, we want to prolong survival. We want to delay the time that it comes back. So hopefully we're not just giving chemotherapy back to back to back. We want to control symptoms of both the disease and treatment. And, we want that woman to enjoy the time that she's got. And this can be achieved a number of ways. The most common thing is we're going to use chemotherapy. We can operate on these women. There's a role for going back and reoperating. Radiation, not a big role. Most of these women are treated with chemotherapy. Probably one of the most exciting things recently is biologic therapies. So, in general, simple GYN oncologist, chemotherapy kills as they replicate. Biologic alters how that cell functions in its sort of day-to-day, minute-to-minute existence. And here again, it's a simple GYN oncologist diagram. This is a cell division, okay? If we're talking chemotherapy, it can maybe keep these chromosomes from replicating, all right? And we've got chemotherapies that do that. You got chemotherapies that prevent the spindles from forming or from separating and allowing it to divide. but you've got a couple points in there where chemotherapy can work in that cell division. That's a diagram, just a simple little one, of the biologic pathways of cancers and some of the growth factors, markers, the cytokines, all these communicating pathways in cell function, you know, and yeah, with both hands, like those neuro guys do. You know, so again, you know, 3 arrows, you know, you've got so many more places that you can impact treatment with these biologic therapies. And again, you know, functions where you can get a hold. With ovarian cancer, evading apoptosis and angiogenesis are probably the two biggies. And, you know, we're moving into an area where we're not just going to look at the cancer and say, oh, that's ovarian cancer, but we're going to start profiling these things with a lot of these molecular signals and figuring out, you know, hey, is there a treatment that's available that we can use? Right now, there's not too much, you know, actionable things that we can use for ovarian cancer. The first one, and the one that right now we're using the most, is targets vascular endothelial growth factor. It's a protein that stimulates angiogenesis. It's involved in embryonic development. It restores oxygen, so it's involved in healing. It develops blood vessels so that healing can take place. If you look at women with diabetes, chronic pulmonary issues, they have higher levels of VEGF in them because you're looking to increase oxygenation when vascular supply is poor. And it's overexpressed in some ovarian cancers and in general associated with poor prognosis. So again, simple diagram, you start out with a little cancer, it's got a bunch of VEGF, it generates blood vessels, now the cancer can grow. Fancy chick embryo studies and studies looking at tumors on, you know, corneas show that a cancer really can't grow bigger than a BB without starting to put down some blood vessels. So VEGF is important in some. Pay attention to my technology here. Ready? Huh? So this is, that was an accident. If anyone can tell me how I did that, please do. So this is basically how VEGF works. There's ways of combating it. But Avastin or bevacizumab is the drug that we have now, which is essentially an antibody against the vascular endothelial growth factor. So it basically prevents the growth factor from binding into the receptor and causing subsequent downstream changes that lead to angiogenesis. There have been multiple trials looking at Avastin. It's approved in Europe, it's approved in this country, different ways and places. As a first-line drug, it's been combined with chemotherapy. Based on a 4-month improvement in progression-free survival, it was approved in Europe for use in first line. It was not in this country. If you remember, this is the drug that was approved in breast cancer, and then the approval was withdrawn because we saw the same thing. The progression-free survival was about 3.5 months in breast cancer. The women where it seems to work the best, when you look at these two studies, they compared chemo versus chemo with Avastin versus chemo with Avastin, and then a year of Avastin. And the women who did best were the ones who got a year of Avastin. So there's been some suggestion that it may be good for consolidation or maintenance. You know, keep women on the drug, it'll improve the progression-free survival before you need to come back. And the place where it looks to be of benefit based on these is, again, in these women who are suboptimal. They have bulky disease. That GOG 262, where they're looking at dose dense, said some of it's been muddied. Part of it is they allowed Avastin in there. And so there's a suggestion that the women who got the Avastin are the ones that were seeing the progression-free survival and not because they got big whomping doses of chemo. It's approved in this country for recurrent disease. It's active as a single agent, so it clicks a bunch of our boxes. Does it prolong survival? No, it doesn't. I mean, we haven't seen anything that truly, you know, again, impacts overall survival, but improves progression-free survival. So as far as, are we going to cure it? No. But it clicks the other boxes. It's a well-tolerated drug. The biggest side effects we see are headaches, nosebleeds, hypertension. It's got some serious side effects. It causes arterial thrombosis. I've seen that once. It can cause GI perforation spontaneously. I have never seen that. So there's serious side effects, but for the most part, women tolerate this. You know, I have a woman with cervix cancer. She's going on her 2nd year of this stuff, and it's working, and she's tolerating. So, you know, yeah, you're coming in for treatment once every 3 weeks, but your cancer's not coming back. So it clicks a number of the boxes for recurrence. Real quick, the second drug, going back to the BRCAs, mentioned that they're tumor suppressor genes. They repair double-stranded DNA breaks. So women who have BRCA mutations can't fix abnormalities in a cancer cell. So the cancer cell starts out, you get some genetic error. If the BRCA is not there to fix it, or something's not there to, you know, it heads off and it'll keep growing, all right? So women with BRCA mutations are very sensitive to an enzyme called PARP. So PARP is another tumor suppressor gene, if you will, or tumor suppressor enzyme that repairs single-stranded DNA breaks. So if the cell has mutated BRCA, it's going to rely on PARP. So if you can come in and block this PARP, then that cell, that cancer cell, now can't fix what's wrong and will eventually die. So olaparib is the most widely tested and was the first to be approved just about a year ago. It's kind of an interesting thing. You know, people talk about, you know, what these drugs cost and all of that, and this is about $8,000 a month. Its initial studies in most cancers were pretty inconclusive, and AstraZeneca bought this from a little company, and they were about to just bail out and take about a $285 million hit on olaparib until someone looked at it and said, hey, it works in these BRCA mutated cancers, and from there we went on. So the trial that eventually got it approved in this country showed a 34% response rate, progression-free survival of 8 months. It is approved as essentially 4th-line chemotherapy for women with BRCA mutations. So, you know, you look at that and you say, 34%, 8 months, whoopee-doo. Well, women who are working on their 4th line of chemotherapy and beyond, that's remarkable. I mean, for the most part, when we're talking about 4th line chemotherapies, I'm talking to women about response rates of 10%, 20% at very best. So, you know, you get something that, you know, doubles to quadruples that. That's pretty impressive. So right now, that's how it's approved here. Interestingly, it is approved as maintenance therapy in Europe. When it was first studied there, it was combined with chemotherapy. They saw about a 4 to 8 month, depending which study, improvement in progression-free survival. So Europe approved it as maintenance therapy. It only comes up really in this country if I'm considering talking to someone about continuing. I saw a lady yesterday, she's been on it for 5 months. Cancer completely vanished in that time. It's a well-tolerated drug. Fatigue and anemia are the 2 biggest things. She's fatigued. She can't even stand it. She's tired of getting blood once every month, so she's going to stop. But, you know, the whole do we continue, do we not, comes up. So again, with olaparib, you know, we're clicking the boxes. It's an easy to handle drug. It improves progression-free survival. It works. it's tolerated, it gets rid of symptoms. You know, again, this woman who just finished 5 months of it started out with all these abnormalities on a scan, ascites, everything's gone. And as soon as we get her feeling better and she's off the drug and she can stay awake, maybe her quality of life will be all right too. So that comes back to the testing these ladies, and you know, pretty much across the board, you know, we're testing these women for BRCA now. So as I said, you know, these targeted or these biologic therapies, it's exciting. This is an incomplete yet nicely alphabetized list of drugs that are out there. Many of them have been studied in ovarian cancer. And unfortunately, like I said, there's 2 of them that work. Some of these on there don't even have trade names yet. They're so early in development. But, you know, I think the biologics are something where, you know, when we're looking at this 10 years from now, you know, when one of y'all's up here and I'm on my deck, you know, hopefully we're going to see, you know, some of the same improvements that we saw, you know, in the 20 years since I came out of fellowship. So other areas, you know, that we're going to see, I think, in the future, you know, trying to figure out why some of these chemotherapies are resistant to chemo, other ways of treatment, you know, how does the body interact with cancer? Are there vaccines? And some of that stuff's exciting, and we hear about it. And, you know, I get patients come in and, you know, Jimmy Carter was cured of this, and, you know, people's, and all that stuff, unfortunately, is, you know, way down in the early phases of this, and not something that, you know, we're going to have ready to give anytime real soon. Certainly we're going to keep looking at other chemotherapies, but, you know, I really think we've probably reached what we've reached with chemotherapy. I mean, we've been through every depths of the sea, jungles of the oceans, and, you know, finding drugs, and, you know, some of the stuff that came through when I was in fellowship would come from jellyfish and marine life that they dug up from somewhere and find some chemical. I think we've reached the end of, you know, a lot of what is chemotherapy, and I think more of it's going to be the biologic stuff. And I think we've really moved from, you know, me on the left there to, you know, Whitney on the right. Thanks, guys. I'm done. Any questions? Sir? Yeah. No, and I don't know that that'll get done, only because really at this point where we limit peritoneal is for optimal. So, you know, if you scope somebody and maybe they have just like miliary stuff and that's all they have and you're not going to operate on them, could you drop a port in and see what happens? Maybe. But I don't know that we're going to know that. It's, you know, one of the things with IP chemo that you always get concerned about is, you know, are you getting a volume, you know, of distribution? Are you getting the chemo to go everywhere? And it doesn't seem to impact anything. It can cause problems with pain, you know, because if you get a bunch of adhesion formation and you're trying to put 2 liters of chemo into the right lower quadrant, it's going to be worse than getting it everywhere. But, you know, when you really break down those studies, whether, you know, it boils down to, you know, about 40% of the women in that last trial were able to get all 6 cycles of IP chemo. And they looked at it as an intent to treat study. So even if you were in the arm for IP and you got none, and they still had that outcome. So it's, you take all those other things, probably, you know, the adhesions and stuff don't matter, but whether or not it causes that stuff, I don't know. I pretty routinely on ovarian cancers leave that Seprafilm stuff, and I think it works. I mean, I don't know if you've ever used it, but I try to prevent the adhesions. But any of these guys who've seen me go back on people, you know, it works to keep adhesions away. I'll wrap it around stomas and all kind. I mean, it works pretty good.
It's curious about the VEGF receptors and such blockade, because even in REI, we're now using as a preventative to ovarian hyperstimulation, we're co-inducing endoscopies.
Really?
And
Yeah, it the Avastin it's something. Bevacizumab is something that I do pull out if there's a lot of ascites, and use it whether by itself or in combination. But it even if you don't see other response to it, it dries up the ascites oftentimes, or pleural effusions.
So you said you used the Avastin for a year, 2 years? Or
It, it's as maintenance treatment. It's for a year.
what about the other one, the
The olaparib to progression, and you're gonna, that you're gonna progress. Again, I mean, I talked to a lady yesterday, about this, and it's not a, well, we can continue it, and it's not a, they're saying, well, for how long, and you got to sit there and say, well, till the cancer comes back, because it's gonna, and we're just trying to keep it from coming back quick, but it's to progression.
Not something you want, but when you do a risk-reducing something, do you recommend consenting for person or risking final?
I do not, unless there's something remarkably suspicious. I don't. The sectioning, the pathologic sectioning of the tube and the ovary for a BRCA carrier is different than for Ms. Jones, who had fibroids. Pathologists will cut an ovary in half. That's it. But they do microsectioning of the ovary and then microsectioning of the tube. So if you do an risk-reducing surgery, make certain that the pathologist knows that you're doing it. Not that you're just sending this, because I mean, standard pathology is cutting the thing in half and taking 3 pieces of the tube, and that's it. But they'll do microsectioning of it in the case of risk-reducing. Now, I don't think you have to do that for, like Ms. Jones, you're taking her tubes out because she's got fibroids, and you just want to take her tubes out because you don't want her to get cancer. I don't think they have to mess with that. But
So it looks like the new recommendations, you said it's no longer first degree relatives, but it's close relatives. Why can't everybody?
well, but it has to be, if you go back to the top of that list, and again, I mean, it's a lot in there, but if you go back to the top of that, it's got to be someone pretty specific. It's got to be someone with this cancer, but with this, and but with that. And so the big triggers are ovarian cancer, early breast cancer, triple-negative breast cancer, male breast cancer. Those are probably the 4 biggies that it doesn't matter how you're related to that person. I mean, yeah.
Do you have a genetic counselor or anything?
So we did. So there is not, now we have someone, a lot of what's happening with genetic counseling, they're hard to come by. You remember genetics, it sucks. They're hard to come, sorry. They're hard to come by. And, we're doing so much more with it. And, they're not reimbursed. Hospital systems don't want to bring in 5 of them because, the stuff's not reimbursed. And that's terrible to say, but that ends up being the gist of it. And then we're dumping more on them. Everyone I see with ovarian cancer, going to the genetic counselor. I'm screening endometrial cancers now for HNPCC. They go, so, I mean, she's just been overwhelmed just by GYN stuff. So, yeah, but we're seeing that across the board. There's not a genetic counselor in the Tri-Cities that I know of. And a lot of genetics now is being handled by, like a nurse who will see that patient, talk to them about it, say, here's how we decide who gets the testing, here's, what that testing means, and then sends them for the testing. And then if they need counseling, there's, nationwide things, like a call-in thing where you say, okay, hey, this person has this, they need counseling. And they do it by phone, essentially, or Skype. But it's something, a lot of places are doing that because, a lot of it's becoming knee jerk. I mean, I just told you everyone with ovarian cancer should get tested. Well, so next time I get one, I'm gonna send it to you, and you can tell her, hey, she's gonna have to be tested. So it's sort of a lot of it can just be run through and tested. Pleasure. Thanks.